Thank you. All right, let's continue with case 7. Our 72-year-old patient has a history of high blood pressure, coronary artery disease, hyperlipidemia, diabetes, and angina, and is taking medications for the same. You decide to take vitals, and his blood pressure is high, really high, 190 over 120, and you get really concerned. He's also tachycardic. With respiratory rate of 14 and SpO2 of 98. Now, looking at this blood pressure, you get concerned. What questions should you ask this patient prior to getting into dental chief complaint? Are you experiencing any chest pain, shortness of breath, dizziness, weakness, visual changes, and headaches? Those are the questions you need answered before you proceed. All right, as you're speaking with your patient, you realize that patient is unable to speak and you see this. Now you get really concerned and you go ahead and check for paralysis on one side and facial droop. You're thinking stroke, and that's correct. Activate EMS, help is on the way. In the meanwhile, our job is to make sure to keep this patient awake and alive. Start with airway, breathing, circulation, basic life support, maintain airway, and monitor vital signs. Let's quickly refer to stroke. There's two kinds of stroke, ischemic and hemorrhagic. And it's important to know the difference because the management depends upon what type of stroke the patient has. Ischemic stroke results from thrombosis, embolism, and reduced blood flow to hypoperfusion to cerebral cortex. And hemorrhagic stroke occurs due to intracerebral or subarachnoid hemorrhage, in other words, rupture of blood vessels in brain. Hypertension is the most common and most important stroke-related risk factor, and other heart diseases and other diseases such as cardiac valvular diseases, prior history of myocardial infarction, atrial fibrillation, endocarditis increases the probability of stroke due to embolism. Similarly, diabetes places patients at a higher risk factor, and patients with bleeding disorders and prescription drugs of anticoagulants put the patient at higher risk for intracerebral or subarachnoid hemorrhage. FAST is an acronym that stands for F as in face drooping, A as in arm weakness, S as in slurred speech or difficulty speech, T, time to call 911. When they get to the hospital, they get neurologic evaluation, a non-contrast brain CT, and IV alteplase is first-line treatment started within 4.5 hours of symptom onset. But there are contraindications to this treatment, and they are if the patient has a history of head trauma or subarachnoid hemorrhage or intracranial hemorrhage or neoplasm, low platelets, and high INR. It's really important to understand that uncontrolled hypertension can cause target organ damage, can lead to MI, stroke, renal failure, peripheral arterial disease, and blindness due to retinopathy due to reduced blood supply to retina. Case 8, a 52-year-old female presents for consultation for evaluation of broken dentition. She has a history of anxiety, depression, COPD, hypertension, congestive heart failure, hyperthyroidism, and Graves' disease, and she takes medications for the same. In order to, her vital signs are normal, and in order to continue with the dental treatment, you kind of want to ascertain if this patient is medically optimized for your procedure. So you go ahead and ask her COPD related questions, such as, do you have shortness of breath, exertional dyspnea? Is there a need for oxygen for you at home? Or do you have a history of hospitalization? And she says no. You move on to asking her hypertension related questions as to how well it is controlled. And she says it's well controlled. You also go further and ask congestive heart failure related questions, such as, do you experience difficulty breathing upon laying flat? Do you experience PND? In other words, do you have to wake up in the middle of your sleep and gasp for air? And can you take care of yourself? And she says yes, and so far so good. You don't forget about the history of hyperthyroidism, and you ask her when was that diagnosed and how well controlled that is. And she mentions it was diagnosed about 3 months ago, and her endocrinologist recommended thyroidectomy, which hasn't been performed. Okay, here we go, red flag, because patients with uncontrolled hyperthyroidism are at higher risk of sustaining a thyroid storm, which is a life-threatening condition characterized by tachycardia, cardiac arrhythmias, death from cardiovascular collapse, hyperpyrexia, agitation, anxiety, delirium, and coma. It is a state of hypermetabolic emergency due to increased catecholamines caused due to Graves' disease, toxic multinodular goiter, and toxic adenoma. Regardless of underlying causes of thyrotoxicosis, a rare state to transition to thyroid storm usually requires a second superimposed insult, such as infection, trauma, history of surgery, or DKA. Treatment of thyroid storm starts with cooling measures, IV fluid resuscitation, electrolyte replacement, antipyretics, beta blockers, and propylthiouracil, and methimazole that prevent beta blocker will help control tachycardia. Propylthiouracil and methimazole will reduce thyroid hormone synthesis. Case 9, a 48-year-old female presents for full maxillary extraction and placement of immediate denture. Past medical history includes anxiety, depression, bipolar disorder, asthma, hypertension, allergic rhinitis, and diabetes. All our patients really sick today, right? And she's on a bunch of medications for same and is well controlled. She tells you that she always needs more lidocaine to get numb. And you go ahead and administer 4 carpules of lidocaine with 2% lidocaine with epinephrine and proceed with extractions. Halfway through, she reports pain, and you administer more local anesthesia. About 10 minutes later, she becomes agitated, anxious, restless, and confused. You stop what you're doing immediately, and you ask her how she's doing. She says not well. Uh-oh. Get her comfortable, get her in supine position, start with basic life support, airway, breathing, circulation, and start thinking and running through her medical history as to what this might be. Now, she has a history of diabetes, she's hypertensive, and she's anxious. So it's quite natural to think that she may have not eaten this morning or may have taken insulin, and so this is hypoglycemia. She didn't take fluids, just drink water this morning, or lack of fluid, hypotension, and most common medical emergency, syncope. You go ahead and take vital signs. She's clearly not hypotensive because her blood pressure is 180/95. Her finger stick is 110, so she's not hypoglycemic. What she might be experiencing? Well, she's more diaphoretic now. She's warm to touch, and she is experiencing convulsions, and you quickly think, well, she has convulsions and tremor, might be seizures. Think about what medications she's on. She's on a bunch of medications for anxiety, depression, bipolar, and that can cause serotonin syndrome, neuroleptic malignant syndrome, and you ended up giving more local anesthesia, possible local anesthesia toxicity. Although local anesthesia toxicity is rarely occurs unless you give patients boatload of medications for local anesthesia, but bottom line, they all seize, and so treatment is symptomatic for right now until they get to the hospital in a safer place. Start with airway, breathing, circulation, oxygen, activate EMS, administer lorazepam. Serotonin syndrome is a life-threatening condition characterized by a triad of mental status changes, autonomic hyperactivity, and neuromuscular abnormality due to increased serotonergic transmission and serotonin drugs. Supportive care, sedation with benzodiazepine, administration of serotonin antagonist is treatment of choice. Neuroleptic malignant syndrome is a life-threatening neurologic emergency characterized by presence of mental status change, rigidity, fever, and autonomic instability, and triggers are antipsychotic agents, anti-Parkinson medication withdrawal, and treatment is sedation, lorazepam. Supportive care. Local anesthesia toxicity characterized by CNS and CVS toxicity, loss of consciousness, seizure, cardiac arrest, arrhythmias. Bottom line, they all start with seizing and then they proceed towards cardiovascular and respiratory collapse. And so symptomatic treatment first with midazolam is important. When it comes to local anesthesia toxicity, treatment with lipid rescue, and knowing the maximum dose with 2% lidocaine plain, 4.5 milligrams per kilogram, 2% lidocaine with epinephrine, 7 milligrams per kilograms, and 0.5% bupivacaine with epinephrine, 1.3 milligrams per kilogram. Last case, case 10, 15-year-old female presents for extraction of 4 caries first molar. They're non-restorable and caries, denies medical history, denies any surgical history, no medications, no allergies. You completed extractions and notice slow, constant ooze that doesn't seem to stop. Bleeding is not profuse, it's slow, constant ooze. So you apply gauze pressure for 20 minutes, use gel foam and sutures, gauze pressure again for 30 minutes. Slow, constant ooze make you think that she may have underlying bleeding condition, and so you obtain hematology consult and further workup. Let's quickly review bleeding disorders, hemophilia A and B, wherein there is a deficiency of factor 8 and 9. For dental extractions, it's important to remember that hematology workup will entail achieving factor levels to about 50 to 70% high preoperatively and maintained at 50% for 5 to 7 days postoperatively. Patients with von Willebrand disease, typically administration of DDAVP or desmopressin helps and is indicated. Management of bleeding intra-op, use of gauze pressure, gel foam, Surgicel, microfibrillar collagen, closed wound with tight sutures, topical thrombin, Amicor, and Amicor rinses and tranexamic acid, and use of surgical splint and stents might be helpful. Let's quickly recap all the medical emergencies and treatment. Syncope treated with aromatic ammonia. Asthma attack treated with albuterol, severe cases epinephrine. Hyperventilation, have them breathe in small brown paper bag. Anaphylactic reaction treated with epinephrine. Epilepsy treated with diazepam. Serotonin syndrome and leptic malignant syndrome is treated with lorazepam. If lorazepam is not available, midazolam works as well. Angina and myocardial infarction follow the ONAM protocol: oxygen, nitroglycerin, aspirin, morphine. Hyperglycemia treated with insulin drip. Hypoglycemia, any oral carbohydrates like oral tablets or orange juice or dextrose IV or IM 1 milligram glucagon. Thyroid storm treated with propylthiouracil, methimazole to reduce thyroid hormone synthesis, and propranolol to reduce tachycardia. Stroke, alteplase if needed or indicated, and local anesthesia toxicity treated with lipid rescue. Bleeding, control with hemostatic agents, hematology consult if the bleeding doesn't stop for further workup, and aspiration and ingestion is treated with basic life support Heimlich maneuver. And thank you very much for letting me complete this topic. A lot of material to cover in 40 minutes, and I really hope you found this useful.
Hello, everyone. I'm very glad to be here with you today. And I'd like to thank Global Summit for giving me the opportunity to participate in this amazing event. And personal to Dr. Kianur that inspire all of us to do always something new. I'm in Athens, Greece. I'm talking from Athens, Greece, and today I would like to talk to you for immediate implant placement in the problematic posterior maxilla without sinus floor elevation. It's very important to mention that this technique, the IPG-DEAD technique, is not a sinus floor elevation technique. What is sinus floor elevation? Very often in the posterior maxilla, we have not enough bone to place implants, to have initial stability to place implants. So we have to go through the sinus floor elevation procedures. So if we have enough bone for initial stability, we elevate the Schneiderian membrane. We place bone graft between membrane and bone crest. We're waiting a few months for new bone regeneration, and we place the implant. If we have bone for initial stability, then we elevate the Schneiderian membrane. We place implant and bone graft contemporaneous, and wait a few months for the bone regeneration. There are two basic methods for performing the sinus floor elevation: the lateral window and the crestal approach. The first who did sinus floor elevation to the lateral window has been Oscar Hill-Tatum 46 years ago. And I must say that no other technique has affected dentistry as much. And there are thousands of other similar methods and techniques. But all these techniques, to succeed, they have a common point, which is no perforation of the sinus membrane. So what they say, if we would like to do sinus floor elevation and we like to have success, we must not perforate the sinus membrane. But IPG-DEAD, what says, yes, you can perforate the sinus membrane. It's no problem to perforate the sinus membrane. The name comes from the IPG is the initial of the founder, and that are the letters from the Dentist Education Institute, where the first surgery took place in 2006. For the first 8 years, we did a lot of clinical research without speak a lot about this technique, because it was really a very innovative technique against everything we knew until that moment. And after 8 years of clinical research, we did our first publication. And the IPG first publication has been cover page in Journal of Implant and Advanced Clinical Dentistry. More with less. This is exactly what this technique offers to the dentist and to the patient. Especially to the dentists who are not familiar with the lateral window. Less flaps, less complications, less pharmacological support, less cost, less time, less learning curve, less aggressive. Is more friendly for the patient, but also for the dentist. And with this technique, we use autologous concentrates and also autologous or allograft stem cells. And this is one research regarding the concentrated growth factors and the CD34 positive stem cells we can find in the peripheral blood. With IPG-DEAD, we can do everything in one session. Implants can be placed even if there is no enough bone for initial stability. And how we can do that? We can do it by using the ATH IPG membrane. And it's an autologous blood-derived membrane that ensures the initial stability of the implant, even if there is no enough bone to provide it. I'd like to show you this video to understand how the elasticity and the strength of this membrane. How I said is a membrane that can retain weight up to 380 grams. It has a very big elasticity and very big. You can see how many instruments we can place on this membrane without the membrane breaks. And you can see the elasticity of we place more and more instruments. And this membrane that comes out of the blood of the patient in 14 minutes. You can see how strong it is. Strong strength and elasticity, and we can place more instruments. So we have a membrane, and now autologous membrane can that can retain weight up to 380 grams. And think, please, how much is the weight of an implant? How much is the weight of an implant? I don't think the weight of an implant is more than half or 1 gram. And here you can see how we can use this membrane, because you can place the membrane in the side, and we can pass the membrane through the side to the sinus, but also one piece of the membrane remains outside. When we screw the implant blocks the membrane between implant surface, implant body, and the bone. So the membrane is sticky, stays here, but when we place the implant, it's also blocked by the implant. So this very strong membrane gives the initial stability to the implant, but also the implant gives stability to the membrane. And we know that this strength and elasticity is due to the incorporation of adhesive glycoproteins. I'd like to show you our first case. First patient of IPG DED technique in 2006. You see that the whole implant is into the sinus. We followed this patient for 15 years. A few years later, we place another implant on the other side, also with IPG technique. And today, a month ago, you can see the CBCT and the panoramic X-ray follow-up of 15 years. You see the implants into the sinus. 15 years post-op. There's another research, 5 years follow-up of 83 implants with sinus membrane perforation and no post-operative complications in the sinus. We have 15 years of clinical research, and there are more than 2,800 cases from many doctors from many countries. One of the latest publications regarding 48 implants and 48 patients with 85 implants, and we have an average of newborn formation of 5.9 millimeters, almost 6 millimeters of the average of the newborn formation. I'd like to show you some cases. Let's see this case here. No bone, we have rotation cheese, but we can place implants here. You see the implants and also the implants after loading 12 months post-op. Here's another case when we have a 3 millimeters initial bone. For initial stability also, but in 2 months you can see new bone formation, and in 4 months you can see and full osseointegration. And we have a lot of live clinical training on this technique. This is another case, old case also, that we place 7 implants. You see here the bone, and you can see here the material around the implants at that time. But we did also 8 months post-op Austal test, and the measurements were good. And what is interesting, I like to show you details of CBCT. You see here pre-op. You can see here very little bone. See here in 4 months new bone formation. But in 8 months, we saw almost 10 millimeters of new bone formation over the sinus floor. And we were really wondering what is going on here. And we did biopsy with the University of Brescia. You see here, no new bone formation, and 8 months post-op, a lot of new bone formation. And we did biopsy, and with the University of Brescia, and we saw that this was really a bone. And we lose this patient, because the lady had didn't came for 10 years in the clinic, and one morning she called and said, I have problems. And you know, when you have placed implants and the patient called and said, I have problem, many strange ideas come to your mind and say, oh my God, what is going on now? But nothing happens. The only problem she had was that the braids get off. And we took an X-ray, a panoramic new X-rays, and you see 10 years post-op, you see here the other teeth. The implants are still there. We cemented the braids and everything was okay. And now it's 12 years. This case is one of the oldest cases, and it's still going well. I'd like to talk to you a little about the protocol to understand how we use and how we do this technique step by step. When we must do immediate implant placement after an extraction, always we use laser for decontamination. We use minimal invasive implantology. We prepare the site less than the implant dimensions. We use condensers. We use an aggressive implant. We use autologous growth factors. We use stem cells. We use autologous membranes. And not always. We use bone graft and titanium mesh. And I like to go one by one to see how we can use all these things, how is the protocols and the steps of this APG DED technique. First of all, after extraction, we always use laser for decontamination. We use minimal invasive or flapless implantology. We don't like to have big flaps. We don't do aggressive strings. We use condensers. We use the first and the second drill, and also we use condensers. Always by hand and very carefully. We don't want to have a lot of, we like always to have the blood circulation. And always we use the hand to feel what we are doing. We use growth factors, and this is a mix with growth factors themselves. And sometimes if we have not bone at all, we use also a bone graft together with the growth factors. There's another research regarding the evolution of this concept. And we use also stem cells. Dr. Garciulo and Dr. Nkingolo, they made amazing work regarding take stem cells from the peripheral blood during the surgery. It's something very new. And you can see here the stem cells, the autologous stem cells. So you use autologous stem cells, and we use also cord blood stem cells, allograft stem cells. We use the autologous ATH-IPG membrane that is very strong, how you saw before, to give the initial stability to the implants when we have no enough bone to give the initial stability. Always we choose aggressive implant. You know, the bone in the upper maxilla is not so good. So I prefer to have an aggressive implant and to use it like a screw. We place the implant into the growth factors and the stem cells, and we create a bioactive membrane around the implant. And you can see how you can see here is the surface around the implant, maybe the perfect surface with autologous proteins, healing and regenerative proteins. So it's a membrane around the implant that gives a surface to the implant of autologous healing and regenerative proteins. And this improve the osseointegration. We have two research on human being regarding this biological membrane, and the results shows that the addition of growth factors had a significantly positive effect on bone formation. We did these two research with the University of Patras and University of Bari in Italy. We place the implants by hand. We like to feel what we're doing. We have not enough bone and we must feel. We don't use the hand pieces. We like to control the speed. We don't like to lose something because we have to go very slowly, very gently, and know exactly what we're doing. Where we place the implants, usually we use a wide cover screw like this one here. So this wide cover screw gives stability, but also is safe. It's safe for the implant. Gives safety to the implant also. But we can use also small titanium mesh for safety and improvement of the initial stability. And we have these two kinds of small titanium mesh that we can use after the implant placement with IPG DED technique. And when we finish, we place the biological membrane and we suturing. There's also an autologous biological membrane. After that, we do also injection with liquid phase stem cells around this area. That also this is very important because improve a lot everything regarding the osseointegration, the new bone formation, and all the healing procedures. So the old school, 46 years now, half century now, says no perforation of the sinus membrane. And down on the planet of today, sinus membrane intentional perforation. And we can do all in one stage surgery. I'd like to show you a video to see how are the procedures with this technique. IPG DED technique. We know that very often in the posterior area of the maxilla, we have not enough bone to place implants and to have the initial stability. So we can use the sinus floor elevation or we can use the IPG DET. With IPG DET, we perforate the membrane. We go with the first or the second drill, perforate the membrane, and we use condenser. But always less dimension than the implant dimension. It's very important. Because we like to use the implant like a screw. We place the special ITH membrane through the side, and you know, always remain here. You see outside, also a piece of this membrane remains here. The membrane is sticky, stays there. We can add bone graft material if we like. And we place the implant into the growth factors to create the biactive membrane around the implant surface. And by hand, we screw the implant in the position. And the implant blocks the membrane around its body, but also the membrane blocks the implant and gives the initial stability. And we place a wide cover screw and the biological membrane. In a few weeks, we have the sinus membrane reconstruction. And in a few months, we have the new bone formation, bone regeneration. The implant is always inside the growth factor and the stem cells. Is never in direct contact with the sinus. This is the IPG DET technique. And I like to show you a few more cases. Let's see this case here. You see how a little bone we have. And you can see this line here is the titanium mesh. You can see here better, the titanium mesh. See here, pre-op, how little bone we have. You see here the detail, the CBC details, and look here, the bone around the implant. Also here, you see 6 months before pre-op and 6 months post-op. And you see the new bone formation around the implant. You see here also the new bone formation around the implant. I like to say regarding this picture here, this is the screw of the healing abutment. But the healing abutment is from Teflon, so we cannot see the healing abutment, we can see only on the screw. But you see how much bone, how much new bone formation we have. Here the same case after loading, and you see the bone around the implant into the sinus. And you see how little bone we have, very little bone. I'd like to show you another interesting thing. This is a case of a colleague that placed an implant with IPG DET technique, and 6 months later, he would like to load this implant, but he couldn't remove the cover screw. Why? Before placing the cover screw, he placed the screw into the betadine solution. So he placed the screw with the betadine solution, and this provoked a lot of problems because couldn't remove the screw. So we had to remove the implant, and you can see how much bone and the fully osteoid degradation around this implant. And 2 days ago, I received a telephone, and they told me that they do everything in the electron microscope, and now we have also the histological exam of this case that we publish in the near future. And we know very well that we have a very good bone. So implant with IPG DET technique and the osseointegration, how much bone has this implant around its surface. So the IPG advantages are many. First of all, we don't care how much bone we have. Of course, it's better if you have 3 or 4 millimeters. But after someone take the experience and place implants also with 1 or 2 millimeters of bone, we have minimal post-op complications. No importance of the sinus membrane perforation. We do the procedures. If we don't have perforation, it's okay. But also if we do the perforation, it's okay, it's the same. We have no pain, edema, or hematoma. Reduced chair time, less graft material needed, overcoming anatomical obstacles and septa, short learning curve, minimal cost. And this is also a key for the IPG DET technique. I'd like to show you something very extreme. What do we have here? We have a case, big cyst in the sinus, no bone at all. Maybe we have also anteroral communication here. Teeth. What do you think? Can you place a direct implant in this case? I'm sure that everyone will say no. We have take out the teeth, do sinus floor elevation, clean the sinus, wait for bone regeneration, and after months, place the implant. So maybe we need 1.5 years to finish this case. But with IPG DET technique, we have 3 cases like that until now. And Professor Francesco Kingolo did this surgery with a great success in 1 session by using autologous stem cells and growth factors. He cleaned the sinus, took out the sinus membrane, placed a bone graft with growth factors and stem cells, and placed the implant. And now is 1.5 years and loading, and this case is doing well. And we have 3 cases like that, so extreme cases. And we do a lot of research also in this kind of case now. So I'd like to say that IPG DET technique is a very innovative technique, but helps a lot doctors to place implant in problematic posterior maxilla. Of course, someone has to be experienced, has to do a course, has to start with less aggressive cases, but is really very friendly for patients and for doctors. I like to say that the WAGRO offers clinical education and master's degrees to who is interested to participate. And I'd like to thank you very much for your attention, and thanks Global Summit for this opportunity. Thank you very much.